Hello, my name is Katarzyna Anadolska. I'm an assistant in radiology department, and I would like to say you something about the radiology in emergency medicine. The most common reasons for patients reporting in ER are injuries, acute belly, neurological disorders, dyspnea, and pain in the chest. As you know, radiologist is very important on ER. The patient that came to the ER usually have um, proposed ultrasound, X-ray, sometimes CT. Why the number of ordered imaging tests still increase? Because we have a wider availability of imaging methods, CT, MR, and the treatment. For example, in three hospitals in Bydgoszcz, we have interventional radiology that works every day. We have increased in the number of suites for medical negligence and malpractice. We have bigger expectations from the patients and the family, and sometimes we use radiology methods when we have difficult in communication patient doctor, for example, when someone is unconscious or we have a language barrier. We will speak about injuries. You can see here the scans from CT. This is foregain object. This is a knife that is in human skull. You can see here an foregain object in the orbit and here in the coronal view. Now we will speak about the most important and very frequent examination that we do in ER department. This is FAST. This is ultrasound, that is focused assessment with sonography for trauma. It's very rapid examination, can be performed in the ER conditions. As you can see, usually in the room in ER, there is a lot of people, nurses, doctors, and the patient, and we don't have a lot of space. And when the patient came to the ER and the doctors start to examination of this patient, we can in the first moment make the fast sonography, and this usually take a few seconds because it is easy examination performed by doctors of various specializations. The test confirms that there is no minor differences in the accuracy of the assessment of this examination. In the most ER room, there is a ultrasound, so this is very so we have a lot big availability to make this examination. Even when we have air ambulance, they also have portable ultrasound machines, and they can inform us if the patient have a big problem because of trauma, for example, pneumothorax or blood in abdomen, that we can assess the medical treatment easier for this patient. What we can achieve thanks FAST. We can detect the intraperitoneal fluid because of trauma. It has a high sensitivity and high specificity. We can find a minimal liquid volume of 500 milliliters, but believe me that we can find a smaller volume also. We can assist in making therapeutic or diagnostic decisions during this examination. We can say to the doctors if the patient can stay and can have CT, or he or her should go now to the operating room and we have no time. This examination replaced the diagnostic peritoneal lavage. It's very that peritoneal lavage is very good examination, but it disrupts the skin and can have also some complication. Sensitivity and specificity is lower in detecting damage of parenchymal organs, because sometimes there are we can see them a little bit later. And a negative result of FAST does not rule slight, very potentially significant bleeding. So usually after FAST ultrasound, the clinicals prescribed CT, trauma CT. And this is a picture that shows us how we make FAST ultrasound. We have few attachment, subcostal, when we can find also inferior vena cava. We have an approach from right upper quadrant, left upper quadrant, and subpubical to examine the pelvis. We will speak what we can see in this approach. Now we will speak about subcostal application. It's very important application because we can exclude if we have a lot of fluid in the pericardial sac. So we can exclude pericardial tamponade, that is life-threatening situation. And usually when we can see bigger measurement than 5 millimeter in pericardial sac, this is a measurement of fluid width. Then we can say that, and this is a bigger volume that we should have. We can assess also inferior vena cava diameter and situation where it changes. It depends on respiratory phase. We will have lower diameter and greater amplitude of changes of inferior vena cava in hypovolemia, and we will have withering of inferior vena cava in heart failure. And the presence of concomitant disease causing pericardial effusion or pericardial cyst may result in false positive result, but it is also important to know about them. And in later examination we will know that why this fluid or cysts are in pericardial sac. On this picture you can see a sonogram of subcostal view, and you can see the heart. Here you can see an anechoic fluid inside ventricles. You can see intraventricular septum. You can see the walls of heart, and here anechoic fluid near to the heart in pericardial sac. We measure the width of it, and if it's bigger than 5-10 millimeter, then we say that we can have pericardial tamponade. We can also report if this fluid is anechoic or echoic, because sometimes we can have blood clot there, and it can be anechoic and unhomogeneous. Another pictures of subcostal view. You can see here inferior vena cava and hepatic veins that drain to her, and you can see that we can measure this vena cava. Normal diameter of her is about 25. When it's bigger, we can say that we have a heart failure of heart, and the blood stays in the vena cava and also in the hepatic veins, and the width of it is bigger. And here you can see the collapse of inferior vena cava. You can see that is a very small diameter of hair, so we can have, for example, hypovolemia because of big bleeding inside, for example, abdomen. Now we will speak about the probe application in upper right quadrant. What we can evaluate thanks this application. We can examine Morrison pouch. This is a space between a liver and the upper pole of a right kidney. We can examine the diaphragmatic area, the right pleural cavity, to evaluate some fluid, and the lower pole of the right kidney. We can also achieve it. And here on the picture you can see Morrison pouch and the free fluid that is in this pouch. This is an region that will be first with the fluid and in the patient that is in the supine position. So it is very important to check exactly if we have some fluid between the liver between the liver and the right kidney. On the picture you can see right pleural cavity. You can see here diaphragm, and below a diaphragm you can see the liver. Here you can see the vertebral line, and here you can see the lung. This anechoic pole is fluid that is inside the pleural cavity. This is a big volume of fluid, and we can report it very fast to the clinicians that we have a hydrothorax, a right hydrothorax. Here on the picture you can see the right kidney. Focus here on the lower pole of this kidney. We can see here single shape fluid, and this collection is has lower echogenicity, but is a little bit heterogeneous. You can see here in the middle part of kidney that the parenchyma is also heterogeneous, and these are the sign of kidney injury. I think that this is a big rupture of kidney. Now we will speak about the left upper quadrant probe application. We can assess in this application spleen area, left pleural cavity, and left pole of the lower kidney. On this picture, you can see very important sign. This is spleen, this is left kidney, and here you can see some heterogeneous, a little bit isoechoic to the spleen, isoechoic fluid. This is a fluid that is between the spleen and between the abdominal wall, and this can be also blood clot. You must remember that usually fluid is anechoic, but when we have some debris inside this fluid, the echogenicity of this fluid will increase. So we will have sometimes heterogeneous, sometimes isoechoic to the parenchyma of organs fluid, and this is difficult to find, so we should be aware of it. If we have some organ that is put a little bit deeper from the abdomen wall because something between them. So we should also report to the clinicians that we suspect here some hematoma. About suprapubic application, we will examine intravesical space, Douglas pouch, and urinary bladder. And here you can see the bladder in sagittal and in coronal view. And you can see here that this is I think that this is a woman, because here you can see the bladder. This is a uterine, and you can see here fluid collections in pelvis. You should also remember that a woman can have anechoic fluid, and this is physiological in pelvis, but it shouldn't be a big collection, only a trace of fluid. And if you see a big collection or free fluid in if you see free fluid in pelvis, a big volume of it, you should in every cases report about this. Here you can see the bladder and the wall of bladder quite good, and you can see here also some portion of free fluid in abdomen. So remember that in women it can be normal, but you should also report about it. Here you can see something echogenic in the bladder, inside of it, in sagittal and in coronal presentation. It's very frequent when we have a patient from big trauma that they have blood clots inside bladder. Why they are in these blood clots in the bladder? Because sometimes we have bladder injury, and the wall can rupture, and we will have the blood clot inside the bladder. But sometimes it is because big injury in of abdomen, and During shaken forces, the mucosa lose some portion of blood that makes a blood clot in the bladder. But it's very important to report about it to the clinicians because they can have problems with catheterization of the bladder. So this is what you can also find in fast ultrasound. Another examination that we can perform in ER department is EFAST. And this is an examination that is extended to include the assessment of the pleural cavity for pneumothorax. We applicate probe longitudinal on the both sides in the mid-clavicular line, high on the chest in 5 till 8 intercostal space. By moving the probe sideways, we can assess the extent of pneumothorax. What difficulties we can have? We can have a small emphysema or subcutaneous emphysema. And this is a situation when free air would stop the ultrasound waves, and we couldn't assess this what is behind the air. Sometimes we have a patient that has a shallow breathing, and this can also be difficult because sometimes this breath is so short that we couldn't assess if this pleura is healthy or not. If we will have a swelling of the subcutaneous tissue, or sometimes we will have obesitas, we have a big difficulties to get to the pleural cavity with our probe waves, and we should and we must report about these difficulties to the clinicians, because then they will perform another examination, for example, trauma CT. And here you can see a picture of a normal lung sliding. You see here the pleural line, and you can see that it moves. Try to focus to see the amplitude of these moves. Here you can see the rib and the acoustic shadow behind it, and another rib, and also the acoustic shadow behind it, because this is a bone. And here you can see the pleura, this hyperechoic thin line that moves in this intercostal space. And here you can see an artifact of a comet tile. That is very important to know how it looks, because in pathology we wouldn't have this characteristic symptom. And now you can see the pneumothorax on EFAST, and you can see here the rib and another rib, and here the intercostal space. You can see the shadow behind the ribs, and you can see here the thin hyperechoic line that is pleural line, and you can see that it doesn't move. We don't have this characteristic amplitude of moving, of sliding, that we have in a healthy lung. We also don't see this characteristic comet tail that we had earlier. So we would report that we have pneumothorax, and we can, if we have time, we can find things moving of the probe, how big the pneumothorax is. But usually we don't have a lot of time in ER room. Usually we say that is pneumothorax, and the clinician decide to go on the CT if the patient will stand it. And here you can see one more time this characteristic lung slide. But how you can examine this, because it can be a little bit hard, especially at the beginning. You should find some point that you will trace. And here on the right zone of this picture, you can see the normal slide of lung. But on the left side, if you will focus there when you see the mark, you see the slide is a little bit abnormal. So it's you will suspect in such a situation that we have a small, but we have probably pneumothorax, and this is what you can all take from this examination, that we have pneumothorax. Even small is a very important sign of injury for the clinicians. Usually when patients have a big trauma, they would have, after first examination and life-threatening treatment, if he can stay it, he will get polytrauma CT. What indications to the polytrauma CT does we have? High energy injuries for in traffic accident, especially in big speed accidents, when the patient fall from a height bigger than 2 meters, when we have an abnormal results of fast test, and when we will have abnormal vital sign. So in every suspicions of organs injury, the clinicians usually make the trauma CT. And what range of trauma CT is? We examine head, cervical spine, chest, abdomen, and pelvis, and we can also extend the examination to the limbs if the clinicians would like to see, for example, lower limb that are broken. Phases after contrast agent administrations we make in the chest, in the abdomen, and the pelvis. Now we will speak about the craniocerebral injuries that a patient that came to the ER department can have, and very frequent have. This is scan of CT. You can see the fracture of frontal right frontal bone here on the actual plane, and on the 3D reconstructions. You can see that the fracture is with displacement of the bone planes inside the pleural cavity. You can see here a subcutaneous hematoma, and also intercerebral hematoma. This is blood that has a high density, so we can say that this is very early acute phase of this bleeding. What examination we can perform to exclude craniocerebral injuries? Sometimes we perform skull X-ray. It has low sensitivity of fracture detection and is not an effective tool for assessing a patient after head injury. But you can ask, why we make it? Usually, pediatrists perform prescribe this examination for children. As you know, children has a big mobility and very frequent they had head injuries. And what the usually doctors routine in such injuries is they observe the patient for 24 hours in pediatric department. So usually they make skull x-ray to exclude big fracture, and if they see that the clinical in clinical examination the patient is quite good, they observe them, and if this clinical situation of this patient isn't worse, and they say that the patient don't have a big craniocerebral injury. If they would have some suspicions that there can be some hematoma or some fracture, they will prescribe CT. But with the ALARA rule, they tried, and we also, to give as lower dose of radiation for pediatric patients as we can. So these are the reasons why we sometimes use skull X-ray. And this all we have also one X-ray that we make in when we suspect injury of nasal bone. And this is a very good X-ray to exclude the nasal bone fracture. What we made also to exclude these injuries, of course, CT of the head without contrast. This is a gold standard to assess of the brain, of the bone structures, soft tissues of the head, eyes, and facial bones. The scope of the examinations should be extended to include the craniocervical junctions, fractures of the occipital condyles that are very frequent missed. So we should always focus on this region, and C1 and C2 vertebra we can also assess in such examinations. Now we will speak about a few conditions that we frequently see in ER department. Subarachnoid bleeding is often in severely injured patients with other intercranial hemorrhagic foci. In CT, we can see hyperdense bands on the cerebellum tend, in the interhemispheric fissure, in the sulcus, hyperdense content in the fluid reservoirs of the base of the brain, the level of hyperdense blood in the ventricles. In such a situation, we must remember that this can be a result of trauma or a result of an aneurysm rupture. So usually after reporting a subarachnoid bleeding, we will make CT angiography to exclude an aneurysm rupture. Here you can see subarachnoid hemorrhage on the scan on CT. You can see here the brain gyri filled with the blood. This hyper dense fluid collections is blood. You can see here an hyper dense falx, and it is also blood, but it's for you it can look quite normal. You should have some practice to recognize it. Another type of head trauma is subdural hematoma. We can find it usually in 15% of brain injuries. This is a characteristic hyperdense crescent-shaped lesion, often extends across the hemisphere. It arises as a result of damage to the veins that drain the subdural space. In the chronic phase, the density of the hematoma is reduced, so the density of blood is changed. Here on the picture you can see the scan from CT in the axial plane. It shows a big subdural hematoma that is in right hemisphere. This is a characteristic crescent-shaped lesions that is hyper dense, a little bit heterogeneous because there is a blood clot that changes during the time. You can see here also the fluid that has a lower density. This big blood clot make a mass effect, and this is a life-threatening conditions. You can see that the mass effect put the brain structures to the left side, and you can see the shift of the septum pellucidum to the left side. And this is severe hernias, the subfalcine um, replacement. So we can see also the displacement of the corpus callosum, and even the ipsilateral lateral ventricle is changed. So this is a life-threatening condition that is the most common cerebral herniation pattern, and it causes subfalcine herniation. Now we will speak about epidural hematoma. Epidural hematoma has lenticular shape. The source of this blood is arterial from the middle meningeal artery, usually. It often coexists with fractures of the bone skull. More often is supratentorial in 19%, and it's very important that is limited by the cranial sutures. And this is the reason why it has lenticular shape, because it couldn't get behind the sutures. It gives the mass effect. It compresses the lateral chamber, displays the middle structures, and it causes also herniations. Here you can see also an actual plane on CT. You can see a big epidural hematoma on the right parieto-occipital region. You can see this lenticular form. You can see also that is heterogeneous inside because the blood clot evaluate, and you can see also this subfalcine herniation that we were speaking earlier. You can see that the right lateral chamber is we don't see it even, and the left lateral chamber is here and is also changed, so the mass effect is here very big. Another situation that we can see in patient in ER is contusion of the brain. Is a result of head injuries in acceleration and deceleration mechanism. We can find the swelling of the brain tissue that we will see in CT as hypodense areas, and small hemorrhagic foci that will be hyperdense. It's a little bit hard to find this contusion of brain on CT. It would be easier to find it on MR. Most often we will find it in the frontal and temporal areas, and sometimes we have Kant cap mechanism when contusion foci are on the opposite side of the injury. And here we have intracerebral and intraventricular bleeding. You can see here bleeding in temporal lobes that is intracerebral, and also you can find here on the right side the intraventricular bleeding in the right lateral ventricle, and you can see also here blood that is in the pericerebral space. Now we will speak about diffuse axonal injury, DIE. DIE is known also as traumatic axonal injury type, and this is a severe form from traumatic brain injury due to shearing forces, and it means that we have direct breakage of the nerve fibers. It is a situation that is potentially difficult to diagnose on CT because there we will have very subtle findings, but clinical we will have a severe neurological impairment, and the diagnosis is usually made on MR because there we will see minor hemorrhagic lesions, and they can be on the gray to white matter junctions or in corpus callosum, and in more severe cases in the brainstem. And this is usually very good to find on SVE, on FLAIR. And now we will speak about brain herniation. We have seen today two subfalcine herniation that are the most common type, and you can see it also here on the highest mark. We can have transtentorial herniations that can be downward when we will have uncals herniation and central herniation, but we can have also upward herniation when it is known as ascending transtentorial herniation. For example, when we will have some masses in cerebellum. And another herniation is tonsillar herniation to the great foramen, and usually it causes the death because we will see clinically the dyspnea in patient, and sometimes the stop of the breathing. Now we will speak about the fractures of the skull bones. We can assess them very good on CT, and we assess also the base of the skull and the fascial skeleton. CT is the best way to assess them. We can propose to the clinicians also 3D reconstructions if they like. We can assess also the bone, where are the bone fragments displacement, and this is very important, especially in brain, especially in some fascial injuries, for example, eye bones injuries. What indirect symptoms of the fractures of the skull bones we will have? When we will see some air in the cranial cavity, when we will see the shading of the air spaces, for example, paranasal sinuses, especially when we will see there fluid level, structures of the middle ear. If they will be shaded, there is a sign of the trauma. It can be a trauma. Slots parallel to the scanning plane may be overlooked in the actual images, so it is very important to see the examination in actual coronal and sagittal planes. And we can always remember about cranial sutures, vascular grooves. Do not mix this with fracture. Here you can see the 3D reconstructions of fracture of face. Bones, you can see the fracture of frontal bone, of maxilla on the both sides. You can see also a combined fracture of mandibula. This is a big injury of face bones. And on the right side you can see another injury change. This is a lenticular dislocation. And we should also in every examination focus on orbits to be sure that these eye sockets are okay. Now we will speak about the chest injuries. On the picture you can see left-sided big chest injury. You can see some fractures of the ribs of the vertebra. You can see here a big wound that goes to the chest wall, to the ribs. You can see here left lung that is collapsed. You can see hydropneumothorax, because you can see here the level of the fluid, and here is and free air inside pleural cavity. You can see big emphysema of soft tissue intramuscle, and here also in subcutaneous tissues. You can see also here free air in mediastinum. So, which methods we can use to evaluate chest injuries? We have X-ray, ultrasound, and CT. And what we can assess to and what we can describe thanks these methods, we can examine pulmonary parenchyma, tracheobronchial tree, large vessels, heart, esophagus, diaphragm, soft tissues, and bone structures. Pneumothorax. Pneumothorax can be a result of penetrating injuries, so it can be direct ingress of atmospheric air into the pleural cavity, or during the blunt injuries. So it could be pressure built up inside the chest, causing the alveoli in the lungs to burst, and it can be also because interruption of the tracheobronchial tree. And life-threatening situation is a tension pneumothorax. This can be a result in cardiopulmonary failure. It is created by the valve mechanism. The air can enter to the pleural cavity but cannot flow out of it. It causes the lung to collapse and the outflow of the venous blood to the heart is impaired. Radiological symptoms is displacement of the mediastinum to the opposite side, fluttering of the concave outline of the diaphragm dome, and withering of the intercostal spaces. And this is a situation that when we see it on CT, we can take the phone and immediately report about this to the clinician. What symptoms of pneumothorax we will see in radiological examinations? We will see the visceral pleura, that is peripheral increase in the clarity and the loss of the vascular drawing. So we should also chase the vascular drawing when it stops, and after a thin line we saw increase of clarity, we should suspect pneumothorax. Lung atelectasis, because it can be because of the mass effect, and indirect symptoms may be emphysema of the subcutaneous tissue. In the presence of the fluid in the pleural cavity, we will find the level of fluid and try to remember about it, because even when you don't see exactly pneumothorax, but you see the level of fluid, you should report about it that you suspect hydropneumothorax. When it's doubt, the X-ray on the exhalation should help, because the reduction of the lung volume and increase of the pleural cavity volume should show us easier the visceral pleura. And here you can see on the X-ray the pneumothorax. Here you can see the drawing of the vessels, and here you can see the pleura, this white thin line, and here you can see the clarity that is free air in the pleural cavity. Another example, this is a hydropneumothorax. So you see the line of fluid that is next to the air, and this is a normal situation when we have a fluid that is near to the air. It always would have a shape of level of fluid, and this is important because sometimes you wouldn't see this lunacy, only this line, and this is also a situation when you should suspect hydropneumothorax. So one more time, this is a lunacy here, that is free air in pleural cavity, and this opacity here, this is fluid, and this is collapsed lung because of this mass effect, because of this air. Here you can see a scan from CT. This is also an axial plane. You can see pneumothorax, but also subcutaneous emphysema and soft tissue emphysema, intermuscle emphysema here. And here on the left side you can see the free air and pleural cavity. Here is a small line of fluid, so this is hydropneumothorax also, and you can see that the lung is collapsed. We can see the changes in pleural in parenchyma. Another situation is contusion of the pulmonary parenchyma. It usually follows the blunt trauma to the chest and typically develops in the area adjacent to the site of impact. During the first 20 hours after the injury, the blood and odematous fluid are collected in the lumen of the alveoli. And in the image of densities of X-ray and CT we will follow. And we will have a resolution of the radiological changes within 2 to 7 days. But we must remember that on the first X-rays we can see nothing that could worry us, but after some hours we will see some densities on X-ray and also on CT that are because of the contusion of the parenchyma. So we should remember to make another examination after a few hours. Here you can see an X-ray of a patient after trauma. He can be now on the intensive care department. On this X-ray you can see a lot of artificial shadows. We had a lot of tubes. We have catheters in the pleural cavity, 2 on the left side, also 2 on the right side. We have a gastric tube and we have also intubation tube. This gastric tube, the sound, it goes below the left diaphragm. We can see here signs of emphysema of soft tissue. This nuances on the left side or behind the chest wall. We can see also the deep sulcus sign here on the left side, the lunacy in the lower pole. We can see here a very important positive bronchogram. This is a situation when we have air in trachea and the bronchi, and you can see here lunacies of bronchial tree. And we see here a lot of small dots that are opacifications because of the fluid that is in the small alveoli, and this is a sign of pulmonary parenchyma contusions. We can follow it also on the right side, and this can evaluate during 7 to 20 days, and when we will focus on lumbar rehabilitation. Another post-traumatic contusion is post-traumatic diaphragmatic hernia. It is inaction of the abdominal structures through the rupture in the central or back of the diaphragm. This is a result of a blunt or penetrating injury of the chest or abdomen. Usually it is on the left side, because on the right side the liver protects the diaphragm dome and absorbs the energy of the injury. The content of the hernia can be small intestine, colon, it can be mesentery, spleen, kidney, left liver lobe, and what affects we can have bowel obstruction due to strangulation, compression of the lungs. And which modality we have? X-ray, X-ray with oral contrast, CT, but also ultrasound, especially in children, but also in the adults. We can see that in pleural cavity are, for example, intestines that moves. And here you can see an bowel inside the pleural cavity, and this is an examination with oral contrast agent. You can see here esophagus and the dilated bowel that are inside the left pleural cavity. Another situation is mediastinal pneumothorax. This is a presence of free gas in the mediastinum. This can be a result of trauma of the lung parenchyma, tracheobronchial tree, the esophagus, the gastrointestinal tract. Free gas from the peritoneal cavity enters the mediastinum through the esophageal hiatus of the diaphragm. It can also be found on the X-ray of chest and can inform us about the gastrointestinal tract contusion. It manifests itself as the presence of gas within the pericardium along the large vessels of the chest, are around the walls of the bronchi and trachea, between the parietal pleura and the diaphragm, and in the soft tissues of the neck and the chest we can have emphysema. And here on the axial plane and the CT you can see free air in the pericardial sac. A little bit about the injuries of thoracic aorta. As this is a common cause of death in ER, and this can be this can be made because of the blunt trauma, because of the fast deceleration, shear forces, damage by bony fragments, sudden increase of hydrostatic pressures. The most common locations of the injuries of the thoracic aorta is aortic isthmus, aortic arch branch region, the level of the diaphragm branch, and sometimes the patient feel quite well even if they have injuries of thoracic aorta, so we must be aware about it. And if we have such a blunt big trauma, we should perform a CT trauma to exclude such injuries. We have a few types of injuries of the thoracic aorta. We can have a minimal aortic damage when we see the damage of the inner membrane without the presence of the hematoma aortically. We can see aortic tear. This is a damage of the inner membrane with the presence of an intramolar hematoma. We can have aortic rupture. It's a disruption of all layers of the aortic wall with the formation of the aortic hematoma or pseudoaneurysm, and dissection. Longitudinal incomplete disruption of the continuity of the wall with the creation of the second blood-filled channel that calls false lumen. And here you can see here an sagittal plane from CT scan, aortic rupture in the isthmus region with the pseudoaneurysm formation. Here you can see the scans from CT, an axial view and a coronal view. This is a post-traumatic aortic dissection. You can see the intimal flap, the double lumen that represents the true and the false lumen. The false lumen is often larger, and because it has bigger pressure, and the true lumen is usually compressed by the higher pressure of the false lumen, and the true lumen is usually smaller. And we can see here also a lower contrast density in the false lumen because of the delayed opacification of this second blood channel. Now we will speak about abdominal injuries. What type we can have? We can have damage of the parenchymal organs that are most often damaged is the spleen. We can have injury to the digestive tract, and most often it is the proximal ileum and duodenum. We can see the damage of the bladder, ureters, genitals. We can recognize damage of the large vessels, the damage of the abdominal wall, diaphragm. Main radiological symptoms of the abdominal injuries are presence of the flesh blood in the peritoneal or extraperitoneal cavity, and that will have a density about 30 to 45 Hounsfield unit. Sentinel clot. This is a reservoir of coagulated blood that would have a big density, about high density, about 60 Hounsfield unit, and it will be near the damaged organ. We can see active hemorrhage, so it will be hyperdense fluid, blush, that we can see in the arterial phase on the CT scan. And this is a situation that we have life-threatening stent. The presence of the free air in the peritoneal cavity, it would suggest us that we have damage to the digestive tract. The passage of the contrast agent into peritoneum from the damaged vessels, lumen of the gastrointestinal tract, or from the damaged parenchyma. Scale of AAST, so it calls American Association for the Surgery of Trauma. We have a 5-level scale of post-traumatic evaluation of the parenchymal organs, and we can describe, thanks this scale, the injury of liver, spleen, kidneys, and pancreas. And it is based on multi-phase CT with assessment of the with contrast agent, and we can assess the parenchymal damage, presence of subscapular hematomas, vascular damage, and it cause of surgical decisions. When damage is assessed bigger than 3 in our scale, then when we have active bleeding, usually the operation will be made. Spleen injuries. They occur in up to 49% of blunt abdominal injuries, so they are quite frequent. It can be damage of the parenchyma, scapular on and interstitial hematoma, active bleeding from damaged vessels, pseudoaneurysm of the spleen, spleen infections, and the complications include delayed spleen rupture, that can be in 5% of the conservatively treated injuries. We can see during the time spleen cysts or abscesses, and pseudoaneurysm of the spleen, or AVM of the spleen, that are made during the time. Here you can see the ASAT scale on the skin, and you can see that we have 5 grades And the first grade, the damage is not so big. We have laceration of or capsular tear and subscapular hematoma. We can have also a damage of parenchyma, but it is smaller than 10%, and the laceration smaller than 1 centimeter in the deep. In the second grade, the dip is bigger till 3 centimeter, and the hematoma parenchymal that is smaller than 5 centimeters. We can see subscapular hematoma that is about 15%, and in the third grade we will have a laceration that is bigger than 3 centimeters, a hematoma that is bigger than 5 centimeters, and subscapular hematoma that is bigger than 15% of surface area. In fourth grade, we will have a laceration of big vessels, vascular injury, intraparenchymal hematoma. We can have devascularization till 75% of parenchyma, and even pseudoaneurysm, arterial vascular fistulas, and confinite active parenchymal bleeding. This is very important to not miss the blush in arterial phase. Grade 5 is shattered spleen. So this is a situation when surgeon will operate also. You can see here axial view in CT scan. You can see here spleen that has a interstitial hematoma smaller than 5 centimeters. We don't see any active bleeding. Of course, we should trace all spleen, and we can propose to the patient conservative treatment here. Liver injuries. Liver injuries occur in 5% of loud abdominal injuries. And injuries include damage to the parenchyma, subscapular and interstitial hematomas, damage to the portal or biliary tract, active bleeding from damaged arteries, and formation of arteriovenous fistula. What complication of liver injury does we have? Biliary peritonitis, biloma, acute non-calcified cholecystitis, delayed bleeding, formation of intra-abdominal abscess, and intra-abdominal crowing syndrome. Here you can see the skull of Assad for liver. Also you can see that the grade 1, 2, and 3, we can see the laceration in 1 till 1 centimeter till 3 centimeter, and in 3 bigger than 3 centimeter. In first grade we will see the subscapular hematoma, smaller than 10%. In second and in the third, we will see subscapular hematoma that is till 50% in grade 2 and bigger than 50% in grade 3. And parenchymal hematoma that is smaller than 10 centimeters in grade 2 and bigger in grade 3. Grade 4 and 5 are big injuries, and fourth, remember that we can see active bleeding in arterial phase. We will have parenchymal disruption of till 75%, and in fifth grade, we will have intrahepatic venosus injury, parenchymal disruption bigger than 75 lobe of liver. And here you can see a big damage of parenchyma of the right lobe. You can see here this heterogeneous hypoechoic region with subscapular hematoma, kidney injuries. They occur in 10% of abdominal injuries, mainly blunt injuries. They are more often damaged in the case of coexisting pathologies of kidneys. For example, horseshoe kidneys, kidney cyst. And if they are isolated injuries, they are usually low-grade injuries. The spectrum of kidney damage includes contusion of the kidney, hematoma, twist, detachment of the vascular pedicle, pseudoaneurysm, blood clots, dissections, and the ruptures of the kidney. We can have a lot of complications of kidney damage. Urinoma is the most common complication, and this is a result of urine leakage and may occur subscapular or directly in the extraperitoneal space. We can observe delayed bleeding within first or second week after injury. We can see renal and perirenal abscesses, hypertensions caused by damage to the kidney, hydronephrosis, pyelonephritis, and also the ASAT scale to the kidney injuries. When in the grade 1 we have only the subscapular hematoma or contusion. In the grade 2 we have perirenal hematoma and laceration that are smaller than 1 centimeter. And the second, in the grade 3, we have vascular injury or active hemorrhage, but confined to the perinephric fascia. And the laceration bigger than 1 centimeter. In the grade 4, we have vein injury, artery injury, segmental or concrete infarct due to vessel thrombosis. We have active bleeding extend beyond the perinephric fascia and laceration with pelvic involvement or ureteropelvic disruption. And grade 5 is a shattered kidney, and this can be also main artery, vein laceration or hilar avulsion. And here you can see injury in the fourth stage, when you can see the damage going from the ileum of the kidney, extensive perirenal hematoma, and the sign of active bleeding. This is a hyperdense pancreatic injuries. They occurs in about 7.5% of blunt abdominal injuries, and they increase the risk of death. Usually they affect the pancreatic body, and rare the head and the neck and the damage spectrum is contusion, damage of parenchyma, hematoma, disruption of the pancreas. We can see the entire thickness disruption or only the part. Possible complication is acute pancreatitis, that it is about 8% of cases. Biliary fistula, production of abscess, bleeding from the parenchyma, pseudoaneurysm, formation of the pancreas. Here we can see an example from CT and actual plane, the pancreas. Here in the middle part of the picture, we can see hypodense region, and this is a complete interruption of the body of pancreas, and you must know that it is very frequent complication of bicycle accidents, so we must pay attention to the children that usually have such accidents. Damage to the digestive tract, usually intestines and mesenteric injuries occurs in about 3% of abdominal blunt injuries and are more common in penetrating injuries. Most often it occurs in duodenum, ileum, colon, less common in the rectum and stomach. We can see perforation, intrawall hematoma, wall swelling after bleeding, rupture, hematoma within mesentery. The glowing, that is very rarely, it is tearing the intestine from the mesentery and the muscle membrane, so the mucosal tube remains. Here you can see the traumatic perforation. You can see the small bubbles of free air and the abdomen. Here you can see the place of the rupture. It isn't usually so easy to find the place, but we are obliged to find this free air bubbles and to report about this. If we can, we should also find this place of rupture. Bladder injuries. Injury of the bladders is relatively common in extensive injuries of the abdominal cavity and the small pelvis. And diagnosis is possible on cystography using X-ray or CT. And we distinguish extraperitoneal perforation and intraperitoneal perforation. Extraperitoneal is more frequent, is damage mainly on the base of the bladder. It's infiltration of the contrast medium into the bladder space, soft tissues of the perineum or tight, the possibility of conservative treatment. Healing on the Foley catheter is often proposed to the patient, and intraperitoneal perforation is a damage of the bladder body and infiltration of the contrast medium into the peritoneum, and the surgical treatment is proposed. Here you can see the pictures from cystography. This is a good one. We don't see any leak of contrast agent behind the bladder that is here full of contrast agent. Here you can see the catheter inside the bladder. Here you see the balloon of catheter, and you can see the leak of the contrast agent into the peritoneum. So we are sure that we have damaged bladder. About acute surgical conditions, we will speak on the seminar, and we will speak about appendicitis, inflammation of the gallbladder, biliary tract, acute pancreatitis, venous thrombosis, pulmonary embolism, gastrointestinal obstruction, perforation, aortic aneurysm rupture, and aortic dissection. So this will be our next seminar. Thank you very much, and these are the sources of this presentation.